Thanks, everybody, for staying for this towards the end of our health innovation platform. Please do come sit up front, and hopefully we can have an engaging and interactive discussion. We'll start with some brief introductions. I'm Svati Shah. I'm a cardiologist at Duke University. I do a lot of stuff in precision health, and I'm on the national board of the American Heart Association. I just finished my term as the research committee chair of the American Heart Association, and I mentioned that to promote that, American Heart Association is really doing a lot in the AI space. And you're going to hear about 2 grants that we awarded to these incredibly talented investigators with one of our biggest investments in AI grants. And we picked these 2 grants because A, they're highly innovative, but B, they will have impact on patients and patient health in a very short period of time. These are 2 different and incredibly exciting grants that you're going to hear about, and we're going to talk through the work that they're doing, as well as obstacles and opportunities as we think about the implementation, the use and implementation of AI to improve cardiovascular health. So with that, I'll turn it over to Dr. Ouyang to introduce himself.
Thank you. Hi, my name is David Ouyang. I'm a general cardiologist and echocardiographer and research scientist at Kaiser Permanente. I also have an adjunct affiliation at Cedars-Sinai. I'm very excited to be here. Should we talk about the grants now, or?
No, let's introduce, because I'm going to ask you guys questions.
Fantastic.
Yeah,
Hello? Actually, my apologies. Hi, everyone. Thank you for staying till the end of things. My name is Cindy Hsu. I am an emergency medicine and critical care physician at the University of Michigan. I'm also the division chief of critical care for the EM department. I'm just so honored to be here and to be awarded by the AHA for this really exciting project that we'll talk about.
Great. Well, again, congratulations to both of you. This was an extremely competitive process. We had 270 applications for these grants, which is sort of unprecedented given the scope of the grant, and you both emerged as the clear innovative science that's going to get done. So I think the first question will be, we would love to hear from you about the work that you proposed and that you're doing that was funded by these American Heart Association grants. So Dr. Hsu, we'll start with you first.
Sure. So our project is called Insight CPR. We have to come up with some kind of sort of catchy name, right? So it stands for Integrated Neural Networks and Wearable Sensor to instantaneously guide hemodynamic directed CPR. And this is really a love letter for all my frontline providers that take care of cardiac arrest patients. And the gist of it is that we fundamentally, have not been able to do patient-centered resuscitation strategy for patients with sudden cardiac arrest. We actually know how we should resuscitate them, which is by determining and assessing in real time their coronary perfusion pressure. There's been decades worth of data, both prospectively and retrospectively, and also in large animal studies, that demonstrated that the higher the diastolic blood pressure, which we're using as a surrogate, practical surrogate in real time as for coronary perfusion pressure, is associated with higher chance of ROS and quicker chance of ROSC, regional spontaneous circulation, and therefore better outcome, survival and neurologic outcome. But practically, we have 2 huge implementation barriers. The first one is the patient needs to have an arterial line in place. And if the patient, especially for out of hospital cardiac arrest and, in the resource limited settings, it's very, very technically challenging to do. And so that's implementation barrier number 1. Second barrier is that, in the ICU and in the hospital, sometimes the patients already have an A line in place. If you attend an ICU and if the patient unfortunately goes into cardiac arrest, you can see that on the arterial waveform, all our monitors these days actually have been trained to detect the peak and the trough of the arterial waveform. So a lot of times with CPR, we generate these negative deflections on the arterial waveform, and you get these negative numbers on the monitor. And so then even if your clinicians know about the diastolic goal-directed CPR, you look up at your monitor and it's a negative number, and the question is, what do we do? So what we're proposing to develop is actually, it's actually 2 products that we're going to try to develop. We've actually started to work on already. One is a software, it's an AI software that is really focused for patients with existing arterial line. And this is based on, we just wrapped up an NINDS R61 grant to develop a large animal model for cardiac arrest with brain injury. And we were able to leverage that data set to really train a series of different neural network models to accurately detect in real time the diastolic blood pressure with, by comparing that with aortic blood pressure and RA pressure, which is the difference between to calculate CPP. So we settled, at least based on that data set, PCN, so fully convolutional model, to basically, we demonstrated with our feasibility pilot data that we can actually use that in real time in the pig lab. Second thing is I partnered with Dr. Ken Odom, who's a mechanical engineer at University of Michigan, and he's been developing this dual sensing sensor, which is both a PPG and a PVDF. So it's both the optical and the pressure sensor, and he actually initially developed to use it non-invasively for patients in shock. But what he discovered with one of his graduate students is that if you put a cuff pressure, essentially a blood pressure cuff on top of that, we could actually both really minimize the amount of artifact, but also kind of leverage the pressure sensor to be able to actually measure the blood pressure in real time. And so we tried that in a pilot animal in cardiac arrest, and it actually did work. And so we were able to use that, and actually that really, I think, really sealed the deal for our grant because we were able to demonstrate feasibility in one animal. So we're trying to develop, by going through prototyping and leveraging our animal model, the sensor, and the sensor is also going to have an embedded AI algorithm to really help us process the real-time data. So, and ultimately, and actually the other thing we're also incorporating is actually design thinking hackathons, and so that we can actually design these innovations with our rescuers for them, basically, because there's a lot of different considerations when your time is of essence, and a lot of times there's a lot of different considerations to be able to use it in cardiac arrest resuscitation. So, and then the third aim is actually we're going to then validate, compare ACLS versus hemodynamically directed CPR strategy in our animal models to compare the survival rate, basically. So that's sort of everything in a nutshell.
That's really fantastic. So, to summarize, the clinical implications of this are pretty massive. Mm-hmm. We know that there's a massive public health burden of out-of-hospital cardiac arrest. We know that even though American Heart Association and all of you have contributed to making sure that people are CPR trained, and we see this on TV shows even, right, where the CPR is delivered very, very poorly, even when you have good training. So, Dr. Shah, the ability to have an easily sort of administered sensor that would monitor quality of the CPR that's done is a really fantastic innovation. So congratulations. And maybe just one follow-up question before I turn it over to David to talk about his grant, which is how do you see embedding in this also feedback? Mm-hmm. I mean, you're doing it in animal models, mm-hmm. but as you move it into humans, mm-hmm. how am I going to know from the sensor, and then is the sensor going to tell me how to do my CPR better? Like, do it faster, do it deeper?
That's a fantastic question. That's a very commonly asked question. We've done a series of interviews with frontline providers, and then through the design workshop, which is like, okay, so let's say your device can tell me exactly what the diastolic blood pressure is, then what, right? And actually, that's something that, based on, so Children's Hospital of Philadelphia, one of our collaborators, Bobby Sutton and Ryan Morgan, they've done a ton of work in both pediatric ICU clinical settings and also in their pediatric swine model. And they developed both a systolic and diastolic goal-directed kind of strategy. And that is, so I think, practically what that means is most likely that you're going to first start by changing your CPR location to really optimize, get the sort of, bang for the buck to really optimize the diastolic blood pressure. Then you're going to move on the next couple of minutes to shortening the dosing frequency of your epinephrine and perhaps add a vasopressin to the non-responder. And then then the next question is, do we activate ECMO, right? Because if you try all these things. Now the other thing that has come up through our workshop is whether we want to embed a clinical algorithm within our devices. It's going to give us prompts, right? Especially, do you tell them to move their hands around? Do you adjust your Lucas? One thing I didn't mention is for the algorithm part, we're actually tapping into our collaborators, like huge data set. So one is the Children's Hospital's ICU recess, 18 pediatric ICU data set with arterial waveforms that they've collected. We're going to curate our own hospital, Michigan Medicine's, both ED and in-hospital data set. That's thousands of patients, and try to find basically we've been banking all the hemodynamic data from the monitor. So we have about, we think, several hundred, probably almost 1,000 patients that may have that data. And then finally, we're actually collaborating with our partners in East Anglian Air Ambulance team in the UK. And this is a very advanced helicopter EMS system that they've had physicians going out to the field and putting in femoral A lines in cardiac arrest patients. So they have a cohort about 100 patients with actual out of hospital arterial waveform data to train. So we have a really diverse data set to train our model, both adult and pediatric, and also in different clinical settings. So.
I love that. So you have high signal to noise data sets where you have the femoral arterial, but then you also have generalizable data sets that are more real world data sets. So
and they are really messy. So our data science team is going through them right now. They're like, this is going to take a lot of work.
I can only imagine. Well, this is true personalized medicine, so congrats. Dr. Ouyang, love to hear about your grant, and congratulations again.
Yeah, no, thank you so much to the American Heart Association. We are extremely grateful for this grant and opportunities to put this to deployment. So I'm an echocardiographer, and I run a research lab focused on AI for echo. It's the top of the funnel. It's really the diagnostic imaging test that nearly all of our patients that we see as cardiologists get. There's rarely a patient that doesn't have an echo. But the key insight we had was that actually there's a lot of information in the images that we as cardiologists don't recognize. One particular example is that there's multiple images of the IVC to assess right atrial pressure, and those pictures actually get many good views of the liver. And the liver is something that, cardiac ultrasound is the same modality as abdominal ultrasound, so it's really a lot of diagnostic images that I, as a cardiologist, am not very comfortable assessing. At the same time, the American Heart Association is really moving into CKM, right? There's tremendous disease with obesity, fatty liver disease, kind of a variety of other causes of cardiovascular burden that is now recently being addressed, but potentially is being under-recognized. So last year, we actually built a large AI model that actually does an end-to-end pipeline to assess for liver disease from the echocardiography images. This was published in the New England Journal AI last year. Yuki was the postdoc that led the work. But the general idea is that we used 70,000 pairs of echoes and abdominal ultrasounds, used the abdominal ultrasound description from the radiologist to train the echo model to identify fatty liver disease and cirrhosis. And the AHA grant is really pushing that to the next level, is now that we have this model, we're going to do a 4-center prospective clinical trial. So Kaiser, Stanford, Cedars-Sinai, and MGH are actually going to prospectively roll this out in the echo lab, actually identify patients that are at high suspicion, and directly link them to gastroenterologists and hepatologists to evaluate if they actually truly have cirrhosis or fatty liver disease. In parallel, we're actually talking with the FDA to actually get this kind of device cleared. And actually this month, we actually received breakthrough device designation. So we're in close collaboration and really hoping that this will actually have a big impact on patient care in the very short term.
Yeah, that's fantastic. We know that there's such a strong bidirectional link between the liver and the heart. And, we're starting to bring together the hepatologists and the cardiologists more in this space, but it's certainly a huge initiative in the cardio-kidney metabolic space. So I have a few follow-up questions. I read echoes too, so are our sonographers going to have to take extra images? Because it's hard. I mean, they have so many images to take already.
Yeah. Our approach is what we describe as opportunistic detection or screening. So it's really using the images that the sonographers already obtain without burdening them with more images, right? It's already a full hour study. They already have to get multiple views to assess the IVC, and those images are already good enough. We really want to utilize, or in order to maximize, I think, clinical value, we want to do it in a way it's not changing the workflow of either cardiologists or sonographers. So we're really the intent of this algorithm is to use the existing images.
That's fantastic. And then a follow-up question. David, you and I have some work that we're doing together where we're trying to actually implement these AI algorithms. And when you have downstream clinical workflows that get affected by that return of that result, how do you think about the balance between positive predictive value and negative predictive value? Our cardiologists say, wait, if you have a poor negative predictive value, you're going to send all these patients to me, and now I'm going to have to deal with them. What's the balance as you think about returning some of these results, and how you balance that aspect of predictive accuracy?
Yeah, the really great thing is that when we talk to hepatologists, they always tell us that they have very empty panels and are excited to see.
Okay.
No, I'm kidding.
Oh,
I'm
I was
kidding.
like, really?
No,
Not at Duke.
Everyone is overworked, and everyone is seeing more patients, and there's a kind of 3 to 5 or to 6 month backlogs for everyone.
Yeah.
So for us, it's a little bit, Svati, like you were saying, that the sweet spot is stakeholder engagement and finding the right patients for the right time.
Yeah.
So for us, we really try to optimize so that specificity is really the name of the game. We are really trying to make sure that we are sending patients that do appear quite sick, that we have strong confidence that they are actually likely to have fatty liver disease and cirrhosis, and really at the highest degree of clinical need. So for us, in discussion with the hepatologist, is really identifying patients with F3 or F4 fibrosis. Really, it's very either cirrhotic or very close to cirrhosis if they have fatty liver disease.
Okay, my next question for both of you, and we'll start with Dr. Shah, is what are technical obstacles that make your work more difficult to do? If you had a magic wand and you could solve some of these so that we could get your grant to have clinical utility in a year instead of 3 years.
Yeah, I mean, there are many. So as I mentioned, I think for sudden cardiac arrest, where time is of the essence, and also what the amount of resource and chaos that always exists in these settings. So we're actually doing our first couple of experiments in the lab, and we have our version 2 prototype that is going to make hopefully they're grounded so that they can withstand defibrillation. So that's actually what we're dealing with right now, which is making sure that our hardware they don't get fried, right, from shocks. And then the other thing which I think, David, you're going to also talk about is about artifacts. So it's extremely noisy. We've got people doing CPR. The patients are getting moved around. We have, the rescuers are moving around. They might be on the ambulance. They might be on the helicopter. They could be, the patient could be on a bed, right? And so I think that all these things, and I think that's why we're so excited to be able to collaborate with our co-Is with their huge data set, which is, it's both in the hospital and out of hospital, and also in the pre-hospital setting. And so, so I think, when we talk to our rescuers, a lot of them are wondering about, things like vibration, things like heat or temperature sensitive issues. I think sound, the noise level, especially if we're going to design something that's going to give voice prompt, is to actually, there's a sound engineering component to it. And then because, so for example, Stryker, their newest AED is CR2. They have this huge team of sound engineers, and so what it does is actually it gets louder and louder. Just based on the ambient noise, basically. So these are all things in the engineering. But so as I mentioned, I think we need to make sure one thing that's loud and clear from our end users is that this has to be integrated within the clinical workflow. It cannot be an additive thing. Ideally, it should replace another task. It needs to be really rugged. It needs to be portable. And it needs to be low cost, because our EMS agencies, the margins is teeny tiny, is really razor thin. And so I'm hoping to really design something that people will actually use, and also we can deploy into essentially across the country, because that's how we can really address the disparity that exists, especially in the rural and urban settings and the resource limited settings. So, yeah.
So yeah, definitely lots of tech challenges in your space, but you're hitting all of them in multiple ways. David, magic wand.
Well, Dr. Shah, we were just chatting before this that you told me you are now the Vice Dean of AI at Duke. So first, congratulations.
Interim.
Interim, but nonetheless, congratulations. Where, if anything, I think you have already seen, both in our kind of project together, our R01 grant, as well as this project, is 98% of the battle is stakeholder management. And many projects, the clinician recognize the clinical value, but then you still have to convince 10 other teams. You have to convince IT, where there's one IT team that's gotten 10 different groups of clinicians saying they all want to implement this tomorrow, and like, how do you triage? How do you evaluate? I guess now that you're the boss, hopefully we can even push this at Duke. But a lot of this is actually getting IT teams recognized and understanding how to integrate with a lot of the different technologies. A lot of these platforms are proprietary, so we have to reverse engineer some of the APIs, but a lot of it is actually how do we actually use it in the clinical workflow.
So let's build on that a little bit, because people talk about the valley of death in translation, and the original valley of death that people talked about was you have something that you find in a mouse, and then you want to make a therapeutic from it, and people always quote that's a mean of 17 years. Where we are now, it's really about the second valley of death. You have something, you have a model, you have a sensor, you have a therapeutic. How do we actually get it to our patients and implement that? So so you made some really good points about stakeholder engagement, working with IT. Can you guys talk to me a little bit more about obstacles and opportunities and how we think about implementation frameworks for the work that you're doing? And Dr. Shah, maybe we'll start with you.
Yeah, so we're focusing at least in the beginning about people who are going to use the device, frontline providers, and who people are making purchasing decisions about buying the device, right? And that's both for the software and and then also device companies. So I think one approach could be that we license the software component to existing defibrillators and AEDs, right, and monitors, right? Because then the software is like immediately available for the patients with A-line already in place. So that's one approach. And it's, a lot of this has to do with really the amount of resource that the different settings have. I think that, if you're at a quaternary center, but not necessarily true anymore. I feel like in this environment, people, the budget is really razor thin. So I think having, clinical champions and to really kind of push and work with their team and understand, and there needs to be a value proposition, right? So, because it's one thing to say we have this new toy we think it's gonna work, but nobody's gonna buy it, or it's too expensive, and frankly, that there's just not a market out there. And I think the last thing I wanna say, which I've learned kind of from our, like going to Stanford and learning about design thinking and working with our collaborators at Blue Cottage, is that when you design for everyone, you design for no one. So I think one of the things that we're talking right now as a team is, I would love for this to go to pre-hospital setting and to our EMS agencies and our helicopter systems. But again, their budget margin is razor thin. But we have, there are EMS agencies that have been able to, deploy different, innovative devices, regardless of the guidelines, right? And so this is something that we've been talking about, which is like, what would it take for somebody to actually implement that in their setting? So.
Great. And David, lots of implementation challenges for the work that you're doing, so would love to hear about what you think those are and how you're trying to solve them.
Yeah, I would say, similar to what Cindy was saying, a lot of it is, at the end of the day, the new valley is the commercial ability or the ability to make a business model around many of these products. So as an academic, various projects we've done in the past, we've both released code and we've released data. Our EF model has actually been prospectively evaluated in a clinical trial, and it's readily available for healthcare systems or people to use. Yet we see no one uses it, right? Even when it's free. And this is really what I mean by, like, really this time we're being very thoughtful on what is the business model around something like this, so that we can actually engage a lot of the device manufacturers or healthcare systems. So in the AI echo space right now, there are CPT codes that requires talking to essentially the AMA as well as kind of CMS and others. There's a regulatory component where through breakthrough, potentially we get to go through the TAP program or kind of figure out what it looks like to actually get this into commercial practice. Even the FDAs now recognize that there's many FDA-cleared products, but for many of them, not much of a business model, so that they've actually established this TAP program, which is to how do we actually then bring it to essentially payers and other places so that there's a financial motivation to actually use some of these devices.
Yeah, that's a really great point. I think so there's the commercialization aspect, and you've always been great in trying to make all your code open source. And then there's the how do you show ROI to payers and to health systems with, Cindy, you had said very thin margins these days. How do you do that? And so hitting that from multiple ways is really smart. Do you guys have solutions for how you sell this? You know, most health systems, I think, are right now not focused on long-term ROI, so making upfront financial commitments for longer-term gain. How do you have any advice for how you talk to health systems and CEOs of health systems and really sell them on, you know, yes, it's important for our patients, but there's a lot of things that they're trying to balance that are important for their patients.
Yeah, from my experience, it really leverages some of the work that we're doing together, which is screening for cardiac amyloid as well as monogenic diseases. Really, where for our amyloid work, we've really seen that there's a lot of synergy with life science. That we see that, you know, obviously tremendous new therapeutics that are incredibly efficacious, but it's a rare disease, so there's a lot of emphasis on patient identification. We're really hoping that, you know, it's still early days, that a similar model can exist around fatty liver disease, right? There's tremendous new therapeutics. We see a lot of booths here for potentially therapeutics for patients with fatty liver disease, and hopefully that they can be engaged in identifying this modifiable risk factor so that there's skin in the game, so that the therapeutic and diagnostic partners can work together.
Yeah, I love that. And also, if we think about using some of those algorithms to identify patients for some of those clinical trials, then you already have some of that already embedded in the health system, and maybe they see the value in it because they see it as part of a research study where they don't have to make the big upfront investment, but then all of a sudden the hepatologists are like, oh, this is fantastic. So I really like that. I don't know, Cindy, if you have other thoughts on your end.
This is a very complicated question, but so I think the public health level, you know, we have in the U.S. over 600,000 sudden cardiac arrests combined, adult and pediatric, a year, right? So and then there's at least 4 to 5 million globally. I think that's underestimated. So I think mathematically, if we can even save 10% of these patients, then that's, you know, in the U.S., almost 70,000 lives saved. And then around the world, and especially if we can build something that is really cost-effective, you know, really low cost and portable. So I think on a public health level, that's one approach. I think on a health system level and I think agency level, if you can demonstrate that, especially if it's integrated with your clinical care already that exists, I think ideally if you can build it in as a capital cost of the hospital, then it gets added onto as a budget. But I think if you can demonstrate to your administrator that ideally it saves lives without incremental increase in costs, then I think, that's a pretty good sell. Even that Michigan is fairly bureaucratic. There's like multiple, so understanding who do you go talk to and how many committees need to go through and make that decision is like really critical. And then I think on a local level, or kind of more personal approach, is actually using stories. So we know we have a huge network, even regionally, with our survivors and co-survivors and our rescuers. We know, for example, one of our nurses in the ED actually recently resuscitated his own uncle in Flint, and they were this family event, and he collapsed, and it just happened that they had one of the 2 AEDs in this rural town, and his uncle walked out of the hospital alive, like 3 days later. After his proximal LAD occlusion, right? And so he's got a great perspective because he is both a nurse in the ED and definitely has resuscitated our patients coming out of hospital arrest, but now with his own uncle, and it's a really great story about his experience in that. So I think using really personal stories, and I think and certainly with champions is really, really, really critical, so.
Yeah, I think that's a great point. The patient stories and engaging with patient advocacy groups in this space where they can help, I don't want to say push back, it sounds negative, right? But to sort of support and amplify our messages with payers, with the government, and with our health systems to say we need to be doing this. I think it's a great point. So in that space, Cindy, I'm hearing a little bit of don't let perfect be the enemy of good with regards to access, but that's my next question, right? So many of us are sort of elite organizations that even though we have thin margins, we still do have resources. How are you both thinking about, there's the generalizability component, right? Like your algorithm itself may perform well in a, urban hospital, but when you get out to a rural population, whether it's because of patient factors or health system factors. So sort of one aspect of the rural component of generalizability of the models and assessment of that. And then second, access. and it doesn't have to be necessarily with the work that you're doing, but generally, how are you all thinking about that, and how can we help make sure that AI is accessible to everyone everywhere?
I think that's a fantastic question. So I've started to think about how can we, with this project, with this just, I think, incredible opportunity to really build the infrastructure. So on the data science side, like how can we build this data set? Because there's nothing that exists right now that focuses on cardiac arrest patients in terms of like multimodal, high resolution, waveform data set. So we've curated this, really very diverse data set. I've written the IRB, which got approved in a way such that we can add additional sites and data into it. We've able to leverage our advanced research computing setup in Michigan, and there's going to be ability to add to it, right? So I think I would love to ultimately make this open access data set so that we could really, as we add more data to it, we can really have human and AI scientists come in and play in this sandbox, because I really feel strongly that we are not the only people who should be working on this. In fact, it really should be a global effort, because that's really what it takes these days, right, to really innovate. I think in terms of implementation and accessibility, so one thing that we discussed, we were blessed to have European partners for this project, and so one thing, the UK and a lot of Norway, they have very advanced pre-hospital helicopter system, and so they can actually deploy this much quicker and early, and they're going to have patients with also A-lines that we can compare with, right? So there's advantages of actually deploying perhaps outside of the U.S. for some of the clinical settings. Yeah. But what is, in terms of regulatory perspective, how do we navigate through that between the FDA and if we were to get the study done outside of the U.S. and so that's something that we're actively discussing right now. Which pathway do we take? Is it a de novo? Is it 510K? I mean, the question really is, we're trying to make the statement that the sensor is trying to measure blood pressure. But we're focusing on specifically doing a cardiac arrest setting because nothing has ever been developed specific for that. But if we say that we're going to also incorporate a clinical algorithm to it, then I think that could have implications about how, and so I think we're going to plan on meeting with, essentially submitting a pre-sub with FDA to really discuss with them what that means and some of the options that we could take. So, yeah.
Yeah, I would say part of the reason why I love Echo or AI for Echo is that it is the top of the funnel. Obviously, other modalities, CT, MRI, are tremendously useful and have their use. But in general, 100 times to 500 times more echoes are done each year in the US. So really, really think that it's democratizing the care that really everyone is already getting so that it has the data and information of more complex methods, right? Many places it's oftentimes easier to find a cardiologist than a hepatologist or get an echo as opposed to MRI. And that's really why the design of this product.
I think that's a great point too. I think in many different AI spaces, if you can come up with a use case that could actually serve as a catalyst for other use cases, right? So if you're able to use Echo, because Echo is very accessible, we can, I think at all of our institutions, it's easier to get an echo than it is a chest x-ray often. So take something that's more accessible, use that as the implementation framework, and then you start building the harder use cases on top of that in these rural health systems. So I really like that too. So I have a question. I think about this a lot in the precision health space. How many different clinical trials do we have to do? Every time you change your model, are you going to do another clinical trial? Do we have to have randomized clinical trials to show that your algorithm directly has clinical utility and not through a surrogate? What level of evidence? Because we think about this a lot in the biomarker side. Are we going to do a clinical trial of every single biomarker and spend millions of dollars to show that this biomarker changes care? Nobody has ever done a clinical trial of showing that checking somebody's creatinine changes an outcome, right? But we use that all the time. So can you talk a little bit about how you're doing a clinical trial? Can you all talk to us a little bit about that, and also with regards to how you talk to the FDA about evidence generation and approval of these devices?
You're asking the tough questions. I wish I had an answer, or I wish I had a thorough answer, but these are the incredibly tough questions that every algorithm developer, commercial and non-commercial, are thinking of right now. The main challenge for AI right now is actually, we've actually published a paper where we surveyed 300 to 1,000 AI clearances in the FDA now. Right now, the FDA is allowing clearances with only retrospective data, right? So the vast majority haven't actually evaluated what it looks like in the clinical workflow, have not done a clinical trial. But because it's relatively permissive to actually get an AI algorithm FDA cleared, the healthcare systems don't know what to do. This is like your new role, as well as many payers are like, actually this is insufficient evidence for me to actually pay you to do this. You can do this because it's FDA cleared, but I'm not sure you'll get reimbursement. But that's where you see companies like Clearly are running the Transform trial, or kind of Ultromics ran the Proteus trial, where it is actually some of this evidence generation is even for the payers, because they want to show that it actually impacts patient care before doing these things. So it's a challenging landscape. I hope that we don't have to do like a prospective clinical trial the same way we do for every single therapeutic, but some kind of prospective evaluation I think is important.
Great. Cindy?
This is perhaps a little provocative, but in the critical care space, RCTs are ways for innovations to go die, basically, because we have not had one that demonstrated really, or we had a phase 2, and then we go to these large RCTs, and then it dies because we can't demonstrate effectiveness, right? So I think it depends on, I think what David really hit the nail on the head, which is what are we trying to claim that it does, right? So for us, it really is, like the first study is actually to, once we have the sensor ready, is to actually put it on, it's a prospective observational study, to put it on patients with already A line in place, and some of them unfortunately will suffer from cardiac arrest, and then we can do essentially a validation studies to demonstrate that, hey, like it's actually really relatively accurate during CPR, and that it's safe, and that it's like accurate. And then I actually feel like the next study is actually not a 1-to-1 RCT. It's actually a step wedge implementation trial, because I think within the resuscitation kind of community, there's enough data out there to get buy-in, and in fact, I think people are going to be excited to implement that. I think we need to figure out what exactly is the implementation package that we're asking them to do, right? And so I think that needs to get flushed out, and that's probably going to be a combination of a smaller, like a phase 2, probably smaller, couple of different sites, and both in adult and pediatric, and then from there on, I really understand and then on top of that, really built in like embedded, I think, mixed methods and implementation studies to really leverage that, basically. So
yeah, I like that a lot. So I think it depends on the use case, it depends on the goals, and there's lots of other methodologies besides our traditional, phase 3 randomized controlled trials for assessing efficacy. Kind of probing a little bit more on this, like what about evidence generation to convince clinicians to uptake some of these algorithms, or what does everybody who's sort of in this AI space need to be thinking about with regards to clinician uptake of these models or sensors or whatever?
Yeah, I would loop it back to your previous question, where for me, for a diagnostic or a detection/screening tool, the name of the game is the PPV, right? Fundamentally, we want to send patients to the right clinician at the right time, and that they don't feel like we're sending so many where the vast majority are false positives. I would frame that there's always a trade-off between sensitivity and specificity, but for better or worse, the loss in sensitivity to get that specificity is standard of care, right? These are the sensitivity, we might not capture everyone, but these are patients that are already undergoing standard of care. So it's not like we're losing or they're not benefiting from this.
Yeah, that's great. Cindy?
So I think having champions, so I think as I mentioned before, it needs to be easy to implement, it needs to be integrative, low cost, and then I think it's interesting because for 2025 guideline actually now have diastolic goal-directed strategies as recommendations for pediatric and say age. Yeah, so for infants of less than a year old, it's 25 or above for diastolic blood pressure, and then for 1 to 18 is 30 or above. AHA did not include anything for the adults, but the ERC, our European colleagues have essentially put in greater than 30 for adults. Having said that, just because it's written within guidelines doesn't mean that people will follow them, and vice versa. So there are things that are written in guidelines that's recommended against that people that then still do, right? So it's a fascinating, I think, kind of human psychology also involved. But I think for the end users, it needs to be practically feasible to actually use in different clinical settings. And then for the payers, purchasers, decision makers, it needs to be cost effective, right? And so, yeah.
So that's an interesting take that I hadn't thought about. I mean, do we need to rethink how we, for AI things, what we consider 2A, 2B, right? The level of evidence for some of this as we try to think about implementing into guidelines, which will be what partially changes clinician and patient uptake. It's a great point. So we have a few minutes left. I don't know if anybody from the audience has questions. But this was really fantastic. I'm so excited about both of your grants. And just to remind everybody, these grants have a very rapid cycle to show clinical impact. They really want to take this and make an impact on patient care within 3 years. I think we're trying to push the envelope of less than 3 years with both of you too, so that we can really show the impact of the work. Both of these investigators, the reason they were selected was the innovation, but as you heard over the past 45 minutes, they are hitting implementation framework in multiple different ways, starting early with multidisciplinary teams, thinking about the use cases, thinking about clinician uptake, thinking about the implementation framework, thinking about regulatory and approval, and then importantly, thinking about how are they going to sell this with regards to ROI to health systems and payers so that we can actually implement this really innovative work and bring it to patients in a short period of time. So these are two really incredible investigators with two incredible projects, and we're so proud to be able to fund you through the American Heart Association for your great work. And thank you for all your time today.
Thank you.
Yeah.